Let me start with my introduction. Hi everyone, I am Malaika and I am part of ECHO India and I'm the relationship manager for Eswatini Hospice. Happy New Year everyone.
Happy New Year. And we have Mr. Simpiwe.
Thank you, Mr. Msanga. I don't know if I'm audible.
We are very loud and loud.
Thank you. My name is Simpiwe Dlamini. I'm a senior nurse advisor for Georgetown. Now I'm supporting the Nazarene clinics in Belubombo and Manzini Richi. So we are pleased to join, I will say, this second cycle for trainings in 2024. Thank you, Hospice, to give us this platform to be able to sharpen our skills in palliative care. Thank you.
Thank you so much. Thank you so much, Mr. Dlamini, to be back. And may I give Nancy Kelelo to lead and the RFN team, I believe, to greet us.
Afternoon, colleagues. My name is Nancy Kelelo from RFM Palliative Care. Happy New Year. Thank you.
Welcome. You're welcome to, we are able to have you in 2024. May I go to Mr. Pennington? Mr. Pennington, can you hear me?
Good afternoon, team. My name is Pennington Dlamini at Eswatini Hospital, working in the Shiselweni region as the palliative care nurse. Happy New Year, colleagues.
Thank you, Mr. Dlamini. We are happy to have you. And may I go to Mazia? Can you hear me, Pat? You can unmute yourself and then talk. Mazia? Are you able to unmute yourself? We can't hear you. Oh. Okay. You can unmute, okay? So we thank you so much, colleagues, for joining, and we are happy that we have all come back in the year, and we are hoping to even have new members who will join the team for the sessions that we will always have in this platform. All in all, what we are trying to do is to share our experiences.
Hello.
And on what. Yes, how are you?
I'm fine. I'm Tabile Mazia from State School Health Lubombo.
We are so much grateful to have you.
Happy New Year.
Thank you so much. We are welcome with that. What I want to say is that we are all welcome in this year, and we are hoping to do better even in this year. This module that we are doing now will take us till May. We are only dealing with most of the common symptoms that are there in palliative care. Last year we were treating in-depth pain, so which all fall under the physical component of palliative care. Then once we are done with the symptom control, then see how we deal with the physical problems that may come with palliative care issues. Then we'll move to the psychosocial and spiritual sides, where we're looking on how we deal with the psychological or the social part, especially in the spiritual side of the patients. So we have introduced and created a group in our where we can a community where we can get instant messages and notifications, other than our emails, where we also share our emails. So you can click in this link at some point, and then you will be able to join our community, which is on WhatsApp, where we are able to share and where you can share your any challenges that you may be facing, or you need some assistance on something, then the team can be readily available to assist you. So we'll be using that one. So now today we'll be covering on the symptom control. So maybe now let's just dive into that and see what we can deal about when we talk about constipation, especially. So we'll be looking one of the situations which is constipation. Let me just emphasize, colleagues, that constipation is a serious problem, especially with these patients who have life-limiting and threatening conditions, and if not well managed, we find that they end up developing complications that tends to be then difficult to deal with. So for that reason, it is very important that we work together and do better and share our own experiences even today on how best you have managed it, and if you have encountered it, how best you have tried it, and what are the principles. So last year, before we closed, we looked at the basic principles that we may use in palliative care when we are managing patient with palliative care conditions. So now we are now beginning to apply those principles that we were treating in that session in depth. So we will be looking today how we can apply those principles in constipation management. So we are going to do that. So for now, let me try to put the presentation here. So even this year, we are looking forward to have different presentation. I'm happy to see my old friend, Joshua Mayo. Welcome. How are you?
I'm fine. I'm fine, friend. How are you?
That's great to hear you say.
Okay, thank you so much for.
Thank you so much for.
Thank you so much for remembering me.
You are well upset. Today we have a challenge of our network, so if ever you are not getting me, please let me so I can be able to redo or read my statements. Can I share? Do you see my slide?
Yes.
You can see it now.
Yeah.
Right. Thank you. Let me do like this. Okay, so we will be looking at constipation. For those who don't know me, I'm Mahlangu Sandile, and I'm working at the Hospice at home, research and training coordinator. So today, what we are going to try to do, we'll be discussing and describing constipation and associated symptoms, and then we'll be looking around on the issues of the pathophysiology of constipation. We'll look at it briefly and then discuss much on the management of constipation. And let me encourage that we all share our experiences with this. I have this picture, which might just give an overview of what exactly is this constipation issue. And so we describe it as an infrequency or a reduced frequency of passage of formed stools and paralyzed by stools that are hard and small and difficult to expel. So we find that it's very tough to go to the toilet and release yourself, especially when you have eaten a guava too much. If you've eaten too much guavas, those fruits, they can deal with you. So that's what we are talking about with these patients. For them, they have not eaten the guava trees or the guava fruit, but they experience such pain and discomfort when they are going to the toilet to pass the stool. So most of the symptoms we can know it involve excessive straining, which later maybe sometimes may result to what we call then constipation, that may result to fecal impatient, and then you will find that patient will then develop what we call piles. So when they develop the anal piles, so we also have that. So it may result to that. So that's why it's very important to manage it as early as possible. And then it may also show some feeling of fullness. Once patients have constipation, they will end up not eating because the stomach is full. There's no air to pass the stool, so you find that it's very distended sometimes. There's a lot of gassing there, and there's pressure in the rectum and incomplete emptying. You know, if you go there you are pushing nothing and nothing is coming out. And as I've said, that there's abdominal distension, and sometimes it comes with cramps. So sometimes the patient presents with abdominal cramping. So you don't rush to Scopex. You need to eliminate issues of constipation because they might be there. So then what have we noticed is that most of the patients who are on palliative care or who are under palliative care or with serious illnesses, 70% of them, statistics or research are proving that they have or they are constipated. As I'm talking now, some of them are in trouble. So that means that this is one of the common symptoms. So if you have 10 patients, you might find that 7 of them will have constipation in their time of or during the disease actual. So once a patient have constipation, one of the problems is that constipation related problems or consequences, the cost that is paid by the patient and also the health system, it's a lot of money, because once they've developed complications, then it means now we are taking a patient to theater. I don't know, I've never been much in theater during my practice, but I am just thinking of how much does it cost one patient to undergo laparotomy in a theater or just an operation. It's millions. Think of if you can have thousands of patients who have developed fecal impaction or who have developed serious complications related to constipation who will undergo such. Some may even end up done colostomy. So if then they have done colostomy, now they have to pay a high amount of money. That colostomy bag each is very expensive. You find that it's more than 30 ml each. And you find that they will use it once in a day, and then let's calculate it in 10 days. That patient is spending 300. In 100 days, it's very expensive. So if we could eliminate that problem or prevent it, we will be doing great for that patient. So another thing that constipation comes with, it has a substantial impact on the quality of life of the patient. It affects the patient psychologically and physically. So you will find the patient unhappy, not enjoying the rest of the life that they have because of what? There's constipation. There's nothing now they're enjoying. What I've experienced is that they even refuse sometimes to take some medications, especially morphine. They end up saying, I better die in pain because of the constipation I once experienced, because of unmanaged constipation. And another thing is that once patient has constipation, that one comes with negative effects on the caregivers, especially the family caregivers for these patients, and then again on the healthcare staff. We are also affected by patient on constipation because the complication that then comes, we don't want more patients to come in our facilities to complain about constipation every day. We would be happy if they could be at home enjoying and have time to see those few cases that needs our attention. But then we find ourselves dealing with constipation. So then all that means we have a serious problem. when we are in palliative care to deal and eliminate constipation or prevent it with all costs that we can. So then if we talk of constipation, then we know we are talking of the bowel system or the GI, the gastrointestinal system, but then we are focusing mostly on the colon and the rectum and the anus. That's our most area. So we are there. So the normal function of the bowel, it includes the ileum, which are the small intestines, the motility, and the colon motility. So once you think of constipation, think of the colon and the ileum in motion. And these two organs, they are always in motion, they are always in movement, and we call this motility peristalsis. Although they are moving, they are making the bolus of whatever the patient is eaten to move. And then when they are doing that, they are aiding digestion, which include the processes of absorption, secretion, and then transportation and storage. So that's the process of this GI system. And then for the motility to do that, if it expulsion and do that, they need some nerves per system. So they use the enteric nervous system. So it means then the nerves, they help these intestines to make the motility, which aids in the expulsion of the waste, and it also aids in the absorption and then in the process of everything that is the secretion of unwanted substances from the body who are within the GI system. So that's what we are normally expecting, that the body is working very well every 5 hours after we have eaten, and then there must be something that the body is doing in a day or 2 or 3 days time. We are expecting someone to have and expel some stools, which is the undigested food or the indigested meal. So we expect that to happen. So we are also looking at around it the issue that there are factors there that we need to understand that affects or that have an impact or promote the well functioning of the bowel. That we know, the first one is fluid intake and adequate dietary fiber and physical activity and adequate time privacy to defecate. So these factors, if then think of the patient who have a life-limiting condition, so it means that if I have this patient, I need to understand that one of the issues this patient is going through is he taking enough fluid, is he taking enough fiber diet, and then physical activity. So is this person able to exercise? How much is this person exercising? So adequate time and privacy. Do you have the time to go to the loo or to the bathroom? So we need to look at issues of privacy. That's why even environmental assessment when we are doing home visits, especially for us as hospice, it's very critical, because in crowded homestays where there is no privacy, you will discover that your patient will end up developing constipation because there was no time to go for outside. And then we have, can I put it in this slide? Sure, yeah. Yes. And then we have what we call a little bit, I don't know why it's misbehaving. They are trying to do something so that it can come. So we are, when we are doing this, and then we have what we call the cause or the etiology of constipation. Can you see? I'm trying to put a slide. Yes, I think now it appears very well. If it's not, okay. I don't know if now you can see my slide very well. Is it okay now? Is it bigger enough for you to see?
Yes, now it is bigger enough to see.
Okay, so then we have the etiologies, the things that normally lead to constipation. So those things, they include one, cancer-related issues. So once a patient is diagnosed with cancer, most of the time, especially when the tumor of that cancer is primarily or secondary on the bowel system. And most of these cancers, we locate them regionally as pelvic cancers. So the cancers that will include prostate, cervical cancer, the cancers that are within the organs that are found in the pelvic region. So these are most cancers that will lead to this. And then also we have the cancers that are within the system, like bowel, like colon cancer, rectal cancer, you see anal cancer. We have many that are there. So if then the tumor is located within the system, then we are expecting that this patient might develop constipation. And then we also have the hypercalcemia, which lead to a decrease in absorption, then which will lead to constipation. So when your patient has hypercalcemia, these patients are at risk of developing constipation, because hypercalcemia then will lead to a decrease in absorption, and then there will be a problem. And then we also have what we call secondary effects related to the disease, which might, by secondary effects, we talk of the issues like appetite loss, anorexia, and then we know one of the symptoms we'll be dealing with in palliative care, we will discuss it at some point in our module. It will be dealing with the issues of appetite. So when your patient is not eating anything, NPO, or is taking less fluid or fiber diet, there is a problem. And then another issue is inactivity, lethargy, or weak body weakness. Some who are confusion and depression and altered normal toilet habits. These also lead to constipation. And another one is the concurrent conditions that the patient has. They may lead to this one, like hormonal one, like hypothyroidism, and then where there's poor water absorption. So this person is always dehydrated, actually. So if this person has a problem, hyperglycemia, especially those who have comorbid of diabetes mellitus, you expect them to have this. Patient with hemorrhoids, patients with neurological diseases, we are expecting them to develop some constipation at some point, if not well managed. And then we also have causes that are medication related, when the very one that is most common and the leading one that is there, that is showcased and difficult to deal with if let loose at some point, which is the opioid medication, especially the common ones, tramadol, Cortec, morphine, fentanyl, there are many, depending on what is available in your facility. But the opioid, once you are engaging a patient on opioid, then you will know that then your patient is at risk of developing constipation, showcase. And then we have anticholinergic drugs, tricyclic drugs like amitriptyline there, which is one of the drugs we are using there, and then antiparkinson's drugs. Another one that we normally not notice, the ions. When we are giving a patient iron supplements, when the patient is taking more iron, then they are at high risk of developing constipation. And then we have some antihypertensive, antihistamines, anti-acid, like the myogels that we use. And then we also have diuretics. So these are the things that we need to think about when we are managing our patients, in terms of, will this not contribute to my patient towards constipation? So we have seen those things, they lead to constipation. But then we need to narrow down to the common one, which is opioid-related constipation. We are saying that most of the patients who are on pain, especially moderate severe pain, they require to be on opioids. So, how the opioids lead to constipation is that they inhibit the propulsive peristaltic system, the ileum and the colon. So what they do, they go to the enteric nervous system, and then they block those nerves. So then the gastric system will stop having motility. So they push everything to sleep. It's like they have a sedating effect to the gastric system. So once you are prescribing the opioids, you know now I am predisposing my client gastric system to sedation. And then when this patient is on chronic use of opioids, which means is on long-term therapy of opioids, we deal with that topic in our previous module. It's still there in our IECO platform. In our YouTube, you can get it at Eswatini Hospice at home in YouTube. You will find them there. So what is there is that constipation is most common to 40% of patients who are non-cancer patients. It means those patients who require severe modern pain, but they don't have cancer. And then if they are taking morphine for a long time, we find that 40% of them will develop constipation. But the strange thing is that when then it comes to, for those then that have bowel dysfunction, especially with advanced cancers, you will find that it will lead to 50 to 90% of those patients, their bowel function will be just dysfunctional, and they will develop a lot of complications, and some they can go at the extent of having fecal infection that may lead to surgery or colostomy. So, and then also what it happens with opioids that it increases the content transit time in the colon. So what does that mean? It means that if there is a bolus that is moving through the colon, or there's food, or there's this digestive material that is going through what the patient is eating, is going through the colon. If it has to take 5 hours, let me make an example, it has to take 2 days, or it has to take a day to pass through the rectum, and then become through a sluice in a day. You will find that because your patient is already taking opioids, that will lead to more than 3 days still running through the gastric system, which then increases fluid and electron absorption. Remember, the colon, its major business is to ensure that it collects its salvage from the digestive material that passed through the intestine that was not absorbed, where it will absorb the electrolytes and the water. So if this bolus is taken very slowly to pass through, what will happen is that stool that is there will be very hard and will end up stuck there, and your patient will develop a complicated constipation. And then the stools will be dry and hard. And for that reason, you'll find that then the patient wants to go to the toilet. Especially then if this has happened in the upper colon, the transverse colon, then you discover even if you put enema, that one will not work because it's very far. And then your patient will be groaning in pain. And sometimes this patient, you find that once the fecal impaction has happened, and then later sometimes you give them a dual laxative, which is stool softer and the stool pusher. And then your patient all of a sudden diarrhea. And then you think you have succeeded, yet there's still a problem because a stool that was so hard and dry is still there. It has never left the colon. Then you might end up taking your patient to the theater because that might lead to even to infection. So if peristalsis changes within 5 to 25 minutes when you are administering an opioid, and this one is also dose related. If I have this patient who's taking morphine for the first time, let me make an example. I'm initiating my patient to morphine. One of the things that will happen is within 5 to 25 minutes, the gastric motility will be lowered. Think of it, then you are going to take it every 4 hours, and you are going to take it for 30 days. What will happen with the gastric motility? The colons, they will go very slowly. Then you find that plus inactivity, plus poor intake of fluids, and a disaster is coming on your way. Your patient might develop very serious constipation. And we need to understand that when it comes to opioid-related constipation, there will never be tolerance for the constipation side effects. Never think that the patient will ever say, now the patient is used to the morphine, he will never develop constipation. That's why we are emphasizing to say, if I'm a nurse and then my physician is prescribing an opioid, and I don't see a laxative there prescribed for the patient, one of the things I need to do is to advocate for that. And then if I'm refilling the morphine for the patient, I'm prescribing the opioid for the patient, whether it's tramadol, whether it's codeine, with morphine. I need then to put a system or a program that will help me monitor my patient's constipation, because I don't want him to experience this type of discomfort. So then when we are assessing the constipation, one of the things we need to do is to understand the past history of the bowel function. It is very important to know how has the patient been going to the bathroom, how is the patient patterns of going to the toilet, because those are the things that help us to help the patient to establish when there is a problem. In short, we establish the baseline. And then once we have the baseline, we will be able to monitor and change and eliminate the root cause of any problem or cause of the constipation. If it's drug related, we'll be able to pick if it's drug related. If it's secondary related, I will be able to pick it. And if it's due to other issues, or if it's the cancer related, I will be able to tell it's the cancer related constipation. So you will be able to tell because you have taken the history of the patient bowel function. So it's very important to know and encourage your patients to know if how is their bowel functioning, where it's going now. And then also you do current physical dysfunction. Any dysfunctions that are there, you do abdominal examination, you do physical exam as important, so that you can identify any physical dysfunction. You will find that your patient has a neurological condition, so cannot detect other things like cannot respond to other stimulus, and then you might know that my patient is I let me make example, patient who suffered stroke. You find that the stroke will then affect the whole lower abdomen, so reaching. And then you find the patient cannot feel anything just below the chest. Your patient may not feel anything. So then now you know that constipation is right here. Anything each other around the pelvic region, the rectum cannot push anything, the muscles, they cannot work. So the fecal incontinence just happen anytime it wants, because the muscles are no longer working, because the nerves, nobody's controlling them. So you will know that. And then another thing that we need to understand, that is the patient or the patient's subjective understanding of constipation for themselves. You know, some patients, they think it's being he or she not to go to the loo for 2 weeks. They can feel they are great. Maybe cultural, I don't know. I cannot go to a toilet that is like one. So you need to understand how they interpret constipation, you know. Maybe for them it's a victory, maybe for them it's a curse from the gods. You know, you don't know. So you need to understand what they understand about it, and when do they consider to say, now I'm constipated. Because constipation, though you may do physical exam and identify, but it's more of a subjective effect. The patient can even indeed I am constipated. So that's why then we are also having the objective measures to document level of constipation. So you can tell that no, my patient is constipated. So there's this one we call the Roman number 4 criteria that is available for clinicians to use, which tells you then now, okay, is my patient constipated or not? So when you are doing your examination or you're doing your assessment, you're using this Roman criteria, then for you to say my patient is constipated, is that in the stools that the patient is passed, 1, 2 or more of these must be present. 1, it must be less than 3 stools a week. If my patient is passing less than 3 stools in 7 days, I might suspect this patient is in constipation. There's straining during more than 25% of the applications. So in the stools that the patient has passed, he has a difficulty passing the stool in a quarter of them, then it's a problem. Or there's a lump or hard stool more than 20% of the application that the patient has had, then that one is there is a constipation we can suspect there. And then sensation of incomplete evacuation more than 25% of the duration. The patient has gone to the bathroom and has passed, but it still feels there's still more left. There's incomplete. Then if the one is there, loose stools are really present without lungs and diffuse. You know, when your patient now is dependent on laxatives, if he has not taken any laxative, there will be no stool. And then your patient has a serious problem. So if 2 or more of these is part of what your patient is presenting with, then it's an issue of in-depth examination that may have constipation. So now we know how we can find it and what might cause it. What is the main goal? Remember, palliative care as a whole is not to cure the patient. The main goal is to promote comfort and improve quality of life. So we want to promote comfort and improve quality of life. And in palliative care, we know quality of life is defined by the patient. So one of the things that we want to get there is to raising of the expectations. Patients have high expectations, you know. So if we are managing constipation, we are trying to plan again, aligning the goals of care so that the patient cannot be discouraged and the expectations can be there. Let me make an example. If my patient is on morphine, and the patient expects to continue enough, have the same bowel function, but not taking laxatives, so we need to reset the expectations. And we know if now it's a tumor that is on the colon, the example that is blocking the root of the material that has to go to the rectum, and then now we need to reset the expectations. Now you cannot use the normal way to pass your stools. We will need to reset the goal, go to colostomy. So now we are changing the goals of care. So that's why we have to manage it. And balance stool frequency and consistency with comfort and dignity. You know, we need to balance the stool frequency, because when we are talking of comfort, we don't want patient to live and sleep and eat their breakfast, lunch, and everything in the door of the toilet. We don't want that because of high frequency of bowel movement. We don't want that. We want them to have time to socialize, have time to play with children, and go to the loo at the right time. At least once in 2 days or 3 days. We want that, or once in a day, depending on the normal pace that they have. 2, we don't want to disgrace our patients. We don't want them to be disgraced. You don't want to improve them. You know, if you have fecal incontinence, you have a problem. If when you are in the loo, you have to cry and shout as a man in the African men West, you know, your dignity goes down. So we don't want them to go to that level. So we want them to gain dignity, have control. We want them to have time to have privacy when they're in the toilet. And then we want to incorporate individual preferences in our care. That's why we are managing. Patients have different preferences. Some will prefer traditional medicine. I want to focus seats. I don't want any Western medication. I have my way of doing things, and then this is what I'm preferring. So we want to look at the preferences. I prefer using a diaper and a linen saver. I prefer to have my own room. So we want to incorporate their preferences in our management of this constipation. And then the basic treatment approach. One of the most important things that we have in palliative care is that prevention is the best treatment. If we can prevent it, then hallelujah, that is good, because prevention is the best treatment. As healthcare workers, the most and cheap thing we can do under palliative care is to prevent constipation. So in prevention, we use the hygienic and dietary rules, which means most of these are our non-pharmacological means, which might include we encourage and ensure our patients are able to get food. PO, they are eating, and they are taking fiber diet, and they are taking fluids. So they are able to take fluids. And then, but we are reasonable with what the patient is, especially when it comes to these hygienic factors. When we go to the toilets, they have enough toilet space and privacy. That's what we call hygienic data. But then, there is one area where we need to be considerate of the ethical principles that applies into palliative care. Even though we want them to eat, have enough fluids, take those, how many liters are we taking now, Mr. Mkanda? How many are we taking now? What is the recommended status? People, in the past it was 1 liter, I don't know, now we are in 3. So now we are in 2 liters, you know? So we are requesting them to take at least fluid that will amount to 2 liters a day. Based on their preferences again, which fluids they prefer. But we need to be considered that as they move with the disease trajectory, whereby they will not be able to take any fluids, people. And that's normal in palliative care, and then we will do end-of-life care, which we will cover when we'll be dealing with how do we deal nutrition and feeding when a patient is approaching the end of life. So where it's possible, you remember one of the principles says reverse the reversible. When the cause or the root cause of constipation is reversible, we are saying put measures to reverse it together with your team. And then we do regular assessment, and then we do medication when appropriate. We apply and use medication. And then what we do again, once you prescribe any intervention, prevention, or medication in palliative care, one of the principles of symptom management is monitoring both efficacy and side effects. That one will continually see it coming in our management. That once I've put a certain intervention and drugs, my responsibility then is to evaluate. Is it doing very well? Is it achieving what we are looking for? How are the side effects? Are they not exceeding the benefits? Then what I have to do, because there's no drug that doesn't have side effects. Then pharmacological interventions, we may include fiber diet, say, increase activity, increase fluid intake, ritualizing bowel habits, you know, even spiritualizing them. Some people, they go to the loo and pray, then they are encounter with the Lord. You know, when they're in the bathroom, that's where they sing, you know. Have you never heard someone say, when I was in the loo, I was singing, and I heard that I was with the angels in heaven? You know? Improve the defecation position, squatting stools. So you can even need to go for environmental scanning. If a patient says a toilet, go look at the toilet seat. There was a toilet, you know, the outside pit latrines in the community there. I know most of us are from there in Africa. I don't know in Europe. Where you find this toilet seat, that when you are sitting on it, your feet cannot touch the floor. So it's very difficult to pass a stool in that seat, and it's very uncomfortable. Now, it's like the one that's sitting, the yellow guy. Even it's better than that one. It's the feet are on the floor. The ones that we have sometimes in the community, so we need to check that one. If my parent is saying I have a difficulty in passing stool sometimes, go check the toilet sometimes, you will find that there is no seat. So the best way to do it is to encourage a position and achieve a 30 degrees. So like the one that is blue there, whereby then you put bricks or whatever material that will raise the feet of the patient so that it will allow the expansion. You know, if you have worked in the labor ward, you are a midwife, you can see that if you can put that guy which is blue in a supine position, that one is a delivery position, I'm telling you. That one is the last push for the woman to deliver a baby. So it is also working when you are helping a patient to pass stools. So we are encouraging that we also check our toilet seats if they are able to help, like the one that is here is the one that we are encouraging. Then I will not dwell much in these drugs, but what I will just say, there are many drugs out there, and most of these pharmacological approaches that we have, they are there as over the counter, they can get them. But then when you are prescribing the you need to know how it is working and what are your objectives. The lubricants, stool softeners, they are good. In the country, we do have mineral oil, we do have liquid paraffin, which falls under lubricant. And then we have performing laboratories. They are not encouraged. They are there, but the challenge is that their side effects, they are too much. So for patients that are dilapidated and they are dehydrated, they will not work. which are most of our patients when they are approaching the end of life. They begin to be dehydrated because they are NPO already. Yet this one requires that the patient is taking more fluid. So in our patients in palliative care, we are not expecting them unless they are still active and they are able to take fluid. But let me focus on saying that we have the biofilming, the lubricants, surfactants, detergents, we have the osmotic laxatives like glucose, we have them in the country with this one, magnesium hydroxide, you know, what we call milk of magnesium, is it that one? And then we have bowel stimulants, the most common one, Senna. We have bisacodyl in the country, then we have sometimes sodium phosphate. But the most common one in the country, in Eswatini, is bisacodyl and the Senna. So we have this one. So these are the good ones, the bowel stimulants. What they do, they increase the motility, right? Morphine lowers down, then this one, they increase the motility. But remember then is, if I'm prescribing morphine or any drug that will lower the motility and increase the transiting time of the stool in the colon, what is going to happen is I'm suspecting that the fluid might be reduced in the lumen and then my stool might be a little bit darker and harder. What will I do to ensure that the liquid heart stool is moving to prevent any rectal collapse and stuff? I will put the lubricant. So I will put those ones. I will combine a stimulant, which might be my bisacodyl, 5 milligrams, I'm making an example, plus 10 mils of a lubricant or liquid paraffin. It's tasty, but they will do that. Or I will use the osmotic laxatives, which might be the lactose. So I might use a stool softener or an osmotic laxative, either of the two plus a stimulant. Remember that sometimes it's very sweet. My experience in the field is that when we encourage them to take both, they never experience constipation. They are okay because it's working very well for them. They are not constipated. The lumen is always hydrated because sometimes you may not guarantee that the patient will take the fluids, which is 2 liters per day. You are not sure. But then if you have the cover-up, which might be the drugs, they will help you, the bisacodyl, which is a stimulant. We also then, when they are NPO, but then we are continuing to take the morphine because morphine you can even give it rectal. We go for the rectal way. We also have the stimulant for those ones. We also have which is the osmotic osmotic laxatives. So we have the fleet enemas and stuff. So you can use those depending on the. Okay, but remember, you know, having a burial anema every day might lead to irritation, and passing stools now and then might lead to irritation. So maybe my conclusion, I would say that one of the things that clinical implications or things that we might not understand as clinicians when we are managing constipation of these patients, we need to know that we should always be proactive in initiating laxative therapy. Don't wait until there is a problem. Prevention is the best management. So be proactive in initiating laxative therapy. In palliative care, we are combining both pharmacological and non-pharmacological. So we start with the non-pharmacological means, then we see. Remember the principles of symptom management says, consider non-pharmacological first because they have the same effect sometimes as pharmacological. For example, in the country or in global, I know, purposely to relieve constipation. When you make the concoction of the purposely, you crush them, you make warm water, then you drink it that, and you find that it encourages expansion of those stools. But you do your examination and you discuss with the patient to see what works for them. And then we should always be alert to medication that can increase constipation risk. So we need to know how much at risk my patient is. My patient is diagnosed with cancer of the colon, and then my patient is bedridden, my patient is taking opioids, my patient is taking certain diuretics, my patient is underlying conditions more than the condition that they have. My patient is severe. So you know, then you are able to monitor them closely. Because sometimes one of the complications that will come with this one, you will find that your patient will have persistent vomiting. And if you don't know, you will continually give them metoclopramide and stuff. Yet you just need to give the Bisacodyl and liquid paraffin or lactose, then they will be done. There will be no vomiting anymore. So we need to know that. Be aware of medication dosing changes. Remember that, especially when it comes to the higher doses of those drugs that lead to constipation, the higher the dose, the more constipated the patient is. So the higher the dose of the morphine, the higher the patient is at risk of developing constipation. So we need to be aware that why it leads to what? Continuous communication and documentation in what we do. If there is no CMIS or what, ensure that whenever you are doing management of your patient, have a prescription sheet that the patient will go with home so we can know what is happening whenever the patient might change his consultation review in his or her next visit. Be aware that prevention constipation whenever possible is the best management strategy. I cannot repeat that many times. Be aware that assistance with oral fluid intake and dietary interventions are helpful. Oral, not IV, oral intake is it can help that one. Aware of and then discuss management needs. Actually, what we're trying to say is discuss everything with the patient so that it can be very effective. The last two things I can say that bowel function requires continuous evaluation to follow disease trajectory and client functional status. We discussed when we started our presentation in 2022, we said patients undergo two phases as they are going. They go into lanes. One is that they go through the functional status. They may use the kiosk, the ECOG, there are many, but they go down with their functional status, and in their palliative care phases, they move down the disease trajectories until they end. So as they move down, their needs in constipation management, they intensify sometimes. You find that instead of having diarrhea, they will end up having more constipation and more constipation. Exercise within each patient's tolerance is recommended to aid elimination. We call it a health activity plan. We need to improve that, and our patient will be doing great in that one. Otherwise, thank you so much. That marks the end of our presentation on constipation. That's what I can say, maybe just to remind us how serious it is to deal with constipation and how best we can try to deal with it. I know we have a lot of to share. Maybe now may I give everyone the opportunity to add something these few minutes. If you want to add something on this management or any question that you might have, you can even share your experiences there before maybe we move to a case presentation by Mr. Amini. May I give this opportunity to you, colleagues? If you have an experience that you might like to share, may I give you this opportunity to do so? Or any question from this presentation about constipation? It might be something from the feed. I'm looking at what people are saying. Yes. So any contribution or any question you might have when it comes to constipation? I'm looking. If anyone wants to unmute and say something concerning this presentation. So this is one of the common problems that we will face or we are facing. Anyone with a comment? Yes, Happy New Year. Yes, maybe we have faced it in our facilities, or you have faced it before, or you have had a patient who is on laxative maybe, but is not working. Or do we have any challenges in the facility when it comes to managing constipation? Maybe resource-wise, maybe technical-wise. Have you ever had a challenge? Or patient-centered problems? Or clinician part of it that you had a problem? Have you ever faced an experience, challenge when it came to constipation management? How do we manage your patient currently in your facility? How do you go about, especially let's take those who are taking morphine? Anyone who may want to share? I know those who are taking options in your facility, I know some of us have that. How do we go about preventing and managing? You can share how have you done it. I know Mazia in the public spectrum. I don't know if they consider such issues when they go through evaluating the public health facilities to see how to palliative care patients access and manage this one symptom. Anyone who has a comment? Have you managed this symptom? Share your experience. Huh? I don't know. I don't want to put someone on the spot, but I like to go for the one that I know in palliative care centers. Let me start with my favorite team. How are you, Smelani Tandazli? You will not hear when we start in the session, but we are grateful and welcoming you in 2021. Would you like to share something? Have you ever been experiencing? Yeah.
Compliments everyone.
Thank you.
Yes, sorry Tim, I joined a bit late, so the reason I'm a bit silent is that I'm trying actually to follow. But yeah, we've had like I think most of our clients, particularly because they have advanced disease, and also the functionality status is greatly gone down. Most of them are ECOG 3, ECOG 4. So yeah, we're having experiencing most of cases of constipation. So from our side, what we normally do is actually to encourage the high fiber diet, fluid intake for those who are able to take. But obviously, you find that there are other issues that you have to consider: renal failures, high hemodilution, and all of that. So you have to balance a number of issues. But usually, what we normally have on our side, it's the stool pushers. Mostly we do not have the osmotic ones, we do not have a softness, but they're doing mostly they're doing well with the stool pushers, because for some, even if you prescribe a softener, they still may not be able to buy. So with the stool pushers, you find that they're doing well. At some point, they even report diarrhea. So then it's a question of balancing. So at some point, you advise them to stop when they are experiencing diarrhea. Otherwise, yeah, mainly it would be that from our side.
Thank you, Simelane. Anyone who wants to add or share, how do you go about it in your facility when you're dealing with constipation in your experience? Thank you so much. Simelane is saying that in their facility they have the stool pushers, which are the stimulants, which might be support your cell. And most of the time the clients are responding very well. Sometimes even they go to diarrhea, then we manage that. That's great. I don't know, anyone else want to share? Okay, maybe can we take Mr. Dlamini's real case on what's happening with this patient? Mr. Dlamini, may I give you this time to share your case? Maybe there's something we can learn from it, and then we can share how best we can deal with a case like this one. Thank you. I hope you will be able to share your screen. All right, Mr. David. Yes, into my work. Yes, we can share your screen, Mr. Lamin. Click share. We can see Zoom what. Okay, just click on the other one with the case. Where is your case? We can see your Zoom, what. We cannot see your case. Maybe if you can open it, and then you will select it when we are sharing. Mr. Dlamini?
Yeah, I'm still trying to find it.
Okay, did you open your case? Because looking at there, it's like you are using your Windows, but it's not yet open because it might show. Maybe if you can go to your desktop and minimize this one and open it. Okay. Are you able now? Okay, minimize your screen that is shown now. Just minimize it. Yes, and then open your case on your desktop. We can see it now there. So just open it there. Open your case. Just click on it there on top of the Zoom. Do you see it now? On top of the Zoom shortcut. Yes, they click the to open, then you will have it. Oh, yeah. There is coming now. Okay. It's still loading. Yeah, you can zoom it by clicking the plus or even a little bit bigger. Click the plus there. Yeah. Okay. Okay. I don't know, I mean, I can see it now. I don't know if what is this now? A little bit smaller, it's now too big. Okay, you can go ahead. Now it's clear.
Good afternoon, colleagues. I'm sorry for the delay, but at last I found my case. My name is Pennington Dlamini, who is working at the Shiselena region under palliative care from Eswatini Hospice at home. Our case, in fact, is a follow-up case, not a new case, which is age 65, a female, was diagnosed with cervical cancer stage 4. The main problem is, sorry. The main problem is severe pain and constipation. The concern is that the pain is worse during the night. Even the constipation is not relieved by the Sarcoti that the client is taking. The chief complaint, patient complains of severe lower abdominal pains, especially during the night. She is always having recurring constipation. Assessment, the pain, characteristics of the pain, it's a visceral pain, and it is located in the lower abdomen. The pain scale is 8, and the pain is worse at night. It is a chronic pain. and it is being aggravated by hard working and relieved by sitting or lying down during the day. The pain results to a limited functionality since he cannot perform hard work. The patient is currently on a strong opioid, of which is morphine, and then it is partially effective because most of the time the pain comes back during the night. The physical aspect assessment. There are no abnormalities under head, ear, eye, ear, nose, and throat. The respirations are normal. The GI system, there's a bowel obstruction due to radiation that was conducted in 2015. And therefore, he has a colostomy in place. He can ambulate with no problem. On the skin is just the incision for the colostomy. Genitourinary, there are episodes of dysuria. Psychological aspect of assessment is worried about the uncontrolled pain. Social aspect assessment, work status was never, the client was never employed, and she went up to secondary school and she is on low class. She is widowed and the habits, no drinking, no smoking. And then relevant health conditions in the close family members. Elder sister died of cervical cancer. Other social related information stays with grandchildren, and the elder son is supporting the family most of the time. Under spirituality, she is a member of a Christian church, and she is able to attend church as she wants. Significant past medical surgical history, radiation and chemotherapy was initiated in 2015. She still continues with chemotherapy. She was done colostomy in 2020 due to bowel obstruction. Past medication was diclofenac and paraquat. Current medication is bisacodyl, morphine, and hydrochlorothiazide. Advanced care planning. A living will, there is no living will. And the DNR orders, no. Advanced decision to refuse treatment, no. Healthcare proxy, yes, it's the son. Mental capacity was assessed and he's mentally stable. There are no signs of mental illness. The vital signs were normal, and the ECOG functionality is at 2. And then other symptoms, the pain scale, as I've mentioned, she's at 8, no dyspnea, no anxiety, no agitation, no depression, no drowsiness or fatigue, no nausea. It's only the pain. Further care plan is adjustment of the morphine dose may help, especially during the night. Yeah, that's the case. Thank you.
I don't know if there's get something from this case, and what can we say about it? This is a woman, 60s, with a history of cancer, and then there's pain that is midnight with a history of complicated bowel function, and then there's a morphine, and then patient is sometimes experiencing dysuria, and yeah. So how do we deal with this patient? Because one of the issues now he has been to operation due to the constipation. How do we help this one? Pain, severe constipation has led to this far. Now he's on colostrum. What do we say? Okay, Mr. Dlamini, you can stop sharing. Stop the sharing. Yes. Yes, I want to see you. What can we do? Yes, thank you so much, Mr. Dlamini. What can we do? Constipation is still there. And there's dysuria. What all this may mean, and the severe pain. And even though advanced characteristics are not that much, but he has made a proxy that should anything bad happen, the son will decide what to happen and on treatment. But then the critical issues that are there is the this unsubsiding pain, regardless of morphine that is given, with the history of complicated constipation, which is fecal impulsion. Yes, Ziggy, you can unmute and say something.
Afternoon, colleagues.
Hello.
From me, I think they can review the dose of the morphine, try to adjust it so that it relieves the pain effectively, and also review the dose of the bisacodyl in order to be in line with the morphine. Because you can find that the dose of morphine is high and they are underdosing the bisacodyl. And also advise the patient on diet, taking high fiber diet, taking a lot of fluids. Yeah, that's all I can say.
Thank you. Nsigi is saying, Mr. Dlamini, may we consider the hygienic factors, which might include fluid intake increase, because maybe the dysuria might be that leak the cause, we don't know. That patient is not taking fluid enough. And then say that please adjust the dose of the morphine to deal with the pain. Yes, what I would say. And already in colostrum, right? You know, my experience that the colostrum is expensive. Some patients go on colostrum, they go for staffing. They are trying to save the colostrum index. I don't know if that might also be now and the case in this one. Anyone else who might want to add? Ziggy is saying we need to consider dietary factors, diet and fluid intake. In our facilities, we have the colostrum index, because might be one of the issues the patient will be complaining of the accessibility. I look at the employment status is not looking good. And there might be a possibility that when we are saying dietary increase, patients might not respond socially, might not be affording and end up not taking. Those recommendations. What I was saying, how best can we attend to that? Anyone wants to add on what Ms. Ziggy has shared already in this scenario? Or if even in your facility you are saying, you know, guys, you can come to Manzini Hospital, colostrum effects, sometimes they are in quantities. So Mr. Dlamini can rush there. What are we saying? How best we can do this? Also, you can see it, you are allowed to share whatever you think can be done in this case, socially, spiritually, physically, and otherwise. What can we do? Yes. What are people saying? the moment of silence. I'm scared. How can we go about this? What can we do? How do we manage constipation when there's colostrum? When now there are no sphincters controlling, everything is going. What can we do as a team to such a patient? This one also has the history that her sister died of cervical cancer. So psychologically, there must be something that must be done on that one to see if it's not affecting his decision and journey, and ascertaining the prognosis of the current condition. I've heard that patient is still on chemo, and how is she progressing on the chemo? Is he on curative chemo now or palliative chemo? I think that one can also assist in designing the goals of care going forward. And then also assessing the level of depression. One of the causes that might lead to constipation is depression. I think you saw it there. So if you're not going to manage depression very well, one of the things that will happen with your patient, it will aggravate constipation. So when you have a patient who's now and then depressed or going anxiety and stress issues, they might end up constipated and not recovering better. So I think that's another issue that we need to do. Yeah. That's it. No, okay. Anyone else before maybe we round up for today? Any comment maybe for the case or presentation or the session for today? Anything to say? We have 2 links that we've shared. So my parting shots for such patients, I would say that it helps to do the medical past history of the bowel function. Even with this one, as Julia said, we need to increase the priority in this situation is the pain management. Remember that when the patient is already on opioids, one of the things that happens with opioids is opioid misuse and then opioid disorders. Do you remember that presentation? So when we are going to increase, we need to also manage those issues, because you might find that you will be continually increasing the dose but not hitting the effects. You need to find out whether the patient is taking the drugs very well, and if not taking them when and how are the patient taking. If they are eating, what are they eating and when? And you know, we need to get all those. So you will find that the problem might be on how the patient is taking the medication for the pain that is not going down at night. So we might need to do that. And another issue is that when it's abdominally related, then is it related to constipation, or is another disease progression, which might be another cancer somewhere? Then it will help us to know then the plan of care going forward on how best we can, because pain is not a ticket for any of the patients to have. So we are trying by all means that they have controlled pain. Then after the pain subsides, we deal with the issue of how is it now continuing with the colostomy management, the psychological effects of the colostomy, the social impact of the colostomy, including financial impact it has on the patient. Then we develop a plan on how best we can manage them going forward and support them in terms of socially, spiritually, and otherwise to manage them to see this. And then it is very important that when the patient has been for so long in curative therapies, you end up knowing how is that impacting the quality of life of the patient that are still on this treatment. Some may end up hopeless, and some end up not willing to be to comply with the treatment. Some may don't know even what is the purpose of taking it for so long. I think that one also needs to be ascertained. Is it still for curatively or is it for palliation? So that you discuss the end of life goals as early as possible. You don't wait until they are unable to talk. So you discuss and plan for the future as early as possible and support them the best we can, because now we know all the goals of care are aligned and the same. in this care. I think that's one of the things I can share from my side concerning the case. If there is nothing I'm leaving behind, may I congratulate all those who received the past module certificates, and may I encourage that we all come and join every day and every time we have a session. Even in this module, we'll have our post session module exam, which is the past exam that help us to bring everything together and check if it is something we've get, that help us also to individually go back and learn other things that are still challenging to us. And we thank everyone, and we hope this year we will all have time to share our cases. And we also encourage that whenever we are joining in groups, may we try to log together and join together in one gadget. It helps us, all of us, to be registered in the platform, and we are looking for greater experiences in this year. I think this marks the end of our session on constipation. Maybe from today, every time we have a patient who is diagnosed and on treatment, may we ensure they are taking laxatives, or they are put hygienic factors to prevent, or measures to prevent and promote bowel movement, so that we don't have complications of constipation. Look at this case we have today. If there was proper management between 2015 to 2020, there will be no colostomy at all. These expenses the patient is in now, there are no way to match. And it's a pain that is very difficult to deal with. So we are encouraging that we prevent as possible as we can. In our next session, we have the fascinating one, the very dynamic and strange symptom to deal with, which is nausea and vomiting in palliative care. It will be on the 24th of January. May we invite others and see and come and discuss how do we deal with nausea and vomiting in palliative care. I hope this was an exciting session for everyone, and we hope we've learned something, and we hope we'll share this. So if you want to be part of the WhatsApp group community, please click on this link above. And we did also share it in our email that we shared on Monday. It is still there. You can click that link and join our WhatsApp community group. It helps us to share instant messages and reminders. And then also we request that you share feedback for us for this session. We appreciate that one so much. We also emphasize the team. We have the resource material available for you in our iEco platform. Every time you just use iEco.org, you log in there, you go to the resource materials, they are there for you. You can use them anytime you want, and they are there. You go to our YouTube channel, you want to watch any session that is there. Since 2022, from what is palliative care to constipation, they are there. We have provided for them, for us all to learn and share our experiences. Have a great day. May you enjoy taking care of your clients. Thank you. Bye-bye.
Thank you so much, all of
Thank you.
you.
Bye.
Bye.
Thank you all. Thank you. Bye-bye.
Bye.
Thanks.